background. I'm going to tell you about a similar study with a very different approach and some different findings, also looking to identify genetic predictors that are associated with increased risk of bony toxicity. So as Seth mentioned, although most children with leukemia get cured, many develop bony toxicity of one type or another, including both increased risk of fractures, broken bones, and osteonecrosis or avascular necrosis. And this can be severe, leading a lot of patients to end up needing hip replacements or joint replacements when there's severe bony damage. The frequency of this side effect varies across clinical trials, but it can be very common, especially among teenagers. What's interesting is that the causes aren't entirely clear. It's when we look at diagnosis, we see that even before we start treatment, patients have low bone density, and this seems to get worse with treatment. We blame, in large part, corticosteroids, which are used throughout leukemia treatment, but other components of leukemia therapy, notably asparaginase and methotrexate, exacerbate bone loss and increase the risk of bone toxicity. As you heard from the last talk, age is a very important predictor. We know that older children, particularly over 10, have a much higher frequency of bone toxicity. But we're not very good at predicting within age categories, and that's why both our groups are looking to identify better predictors of bone toxicity within age categories. And you know, in short, we're trying to understand why, if we're giving all children the same therapy, some patients develop this toxicity and not others. And so we also were looking for genetic variants that might be associated with increased risk. We took a different approach. Rather than doing a genome-wide approach looking for new variants, what we did was we selected a list of common genetic variants in genes that we selected a priori because they might be related to bone metabolism or risk of drug-induced toxicity. And of these genes, we looked for variants that are known to occur in the population relatively commonly. More than 15% of the population will have one of these variants. And we did this study among patients treated on a Dana-Farber Leukemia Consortium protocol, which had over 600 patients, and I show the incidence of either fracture or osteonecrosis shown here. And this is the long list of genes that you can ignore. Because of this list of genes, the one that we found that was most relevant was a variant within the promoter for thymidylate synthase. There's a 28 nucleotide repeat that repeats either 2 times or 3 times, and we found that the patients who had 2 copies of a gene with only 2 repeats of the 28 nucleotide repeat, the 2R2R genotype, almost 21% of the patients had this variant, and those who had the variant had an increased risk of bony toxicity. What was very interesting was that the risk differed by age category. So when you look at the very bottom of the slide, the young patients who had this variant were almost 3 times as likely to experience osteonecrosis as the remaining patients who did not have, who were not homozygous for the variant. Among older patients, those who were homozygous for this variant had a 2-fold increased risk of bone fractures, a different toxicity. And that's shown graphically on the right, showing the incidence over time of osteonecrosis in the young patients, which is higher. The red line are the patients who are homozygous for the variant compared to the dotted blue line. And the bottom curve is the older patients, showing the increased risk of bone fracture. So what is thymidylate synthase? It's a gene that's necessary for the synthesis of one of the DNA precursors, one of the nucleotides, thymidine. And it is inhibited both directly and indirectly by one of the drugs we use in curing patients with leukemia, methotrexate. So the number of 28 base pair nucleotide repeats in the promoter is associated with the expression of this protein. It has to do with the efficiency of translation. So the patients who are homozygous for the 2R variant have less expression of the TS protein, which we would predict would lead to increased sensitivity to methotrexate, probably especially in the setting of low folate conditions. So in summary, this common genotype, this common genetic variant was associated with an increased risk of bone toxicity among children treated for leukemia. Interestingly, we also saw a difference by age category. So again, the young patients who had this variant had almost a 3-fold increased risk of osteonecrosis, while older patients with this variant had a 2-fold increased risk of fracture. And so we think that going forward, patients who have this variant should probably have increased surveillance for bony toxicity. And it supports the importance of the chemotherapy drug methotrexate in the pathogenesis of bone toxicity, but interestingly suggests that the pathophysiology may be different between the younger and the older patients.